the first free paper 454. Dr. Suraj Singh Sengam, are you here? Yes, he will be speaking on blinding ROP, the need for rehabilitation training packages.
Yeah, thank you. Thank you, ma'am. So, thank you for this opportunity. So, my topic is blinding ROP, the needs for rehabilitation training package. So, I will start with my financial disclosures. So, I don't have any financial disclosures to show, and no conflict of interest as well.
Is your mic working?
Sorry. So, let's have a quick look. This child had never seen how people walk. So this child just, you can focus how his legs moves. So he has never seen human beings walk. So this is the clinic where I have started in 2018, Dr. Rajendra Prasad Center for Ophthalmology Sciences, New Delhi. So in 2018, so so we have registered blinding ROP, nearly about 336 babies blinding ROP. So as you know that blinding ROP, so there's a lot of negative impact in terms of learning and development and cognitive skills development. So for that, so we know that the sight is being lost. Then what else that we can use to improve the child's learning skills and developmental as well as the cognitive skills. So we must remember the other body senses that we have sound, touch, smells as well. Then the last option is the rehabilitation services. Then what is a rehabilitation then? The rehabilitation is a child is learning how to do something for the first time. See, a child has to learn it, how to walk, so which has never done before. So that is the rehabilitation. So as you know that the evidence are quite available nowadays, that early rehabilitation in a child with the blinding ROP, so there are lots of improvement in terms of learning, developmental, motor skills, and as well your cognitive skill as well. And the aim of this study is development of rehabilitation service package for children with blinding ROP, that is stage 4 and 5. So we use the three different techniques. The first is the extensive literature search. The second is observation in my clinic. So we interact with the patient and the caregiver. The third is open-ended question. So literature search, we do a couple of literature search. We want to know what options are available for this child's ROP to develop, enhance their skills and their cognitive skills and other learning. And this is the interactions is very important, so we must focus is how we interact with the patients so that we can improve those skills among the children, ROP blind. So this is open-ended question, we use it. So we purposely selected parents and caregivers, and then we ask the questions. So suppose a child is able to identify the objects. Okay, this is a spoon, this is a glass, and then the child is able to work comfortably in our clinics, then we choose those patients for the interview. So coming to results, remember most of these skills we learn from the parents. We learn from the patient itself. So when we observe it and then we learn, we interact with the patients. So the first we categorize into essential life skills and instrumental life skills. So you will not find these topics in other literature. So in the essential life skills, there may be a couple of, but we focus in this presentation. There's a mobility, social smile, and communications training in blinding ROP child. And the instrumental life skill is object identifications, because they have never seen what are the objects available to their surrounding. So just quick focus in this. So we ask the parents, so please show us how to make your child laugh. We don't know, because we are clinician. We don't know how you make child laugh. So this mother, initially he tried, okay, with the nose-to-nose contact. We learn from the parents, nose-to-nose contact, and then he, tickle among to her baby's face. And then different technique we use it. We observe it very carefully. So I will do a little bit forward. So see the tickling in the face. And then finally, the child will start laughing when the mother tickle on her cheek. So we learn these techniques while we observe carefully in our clinic. So this is the technique, communication learning. So the first one is the fathers try to communicate with his blinding ROP child. So this is the wrong way. The second one is very interesting. The mother was sitting at the outside, at the settee, and then when you ask them, you try to communicate with your child. And then mother immediately came down and sit on the floor. See the level of at a similar level. So you'll see the video here. It's very interesting. So this is a mobility training. We also learn from the parents. So this is two-parent techniques. So these parents try to teach that how to walk. And this is the one child with the musical toys in the clinic. So this is very interesting. This also we learn from the parents. So the child is used some kind of tripod to start with the independent mobility.
Try to finish, doctor.
Yeah.
Time's up.
Yeah. Last few slides. So this is the mobility training. start with the how to provide the cane training, and this is the cane. So last slide, so, yeah, we started cane training after we know that there are, this is object permanent means the finger to finger we use, we learn from the parents. So to conclude is, we develop some kind of techniques for the mobility. We use the two-parent technique, one-parent techniques with the toys, without toys, and object permanence. We use the finger-to-finger over techniques for the blinding ROP side. And this is the age-appropriate rehabilitation service from birth to 3 years, preschool age, and school age children. And last slide. So observation is very important in the clinics, so that the rest of the child we can teach them. The most critical period for rehabilitation service is 2 to 3 years. Thank you, sir. Thank you.
I have only one question.
Yes, sure.
There are so many other conditions where babies
Yes,
are blind
very
since
true.
birth.
Very true.
Why do you select only ROP babies?
Very true. So, so recently we have started this ROP clinic in RP center. No, rehabilitation services. So in a week, around 3 days in a week. So this ROP clinic, they refer to blinding ROP. And we know that there are lots of issues, that there may be some neurodevelopmental disorder. But while we developed this rehabilitation package, we purposely selected the caregivers that the child is able to work comfortably in our clinic, and we with the orientation with the sound technique. Then we interview those parents, and at the same time we record a video, and then we started documenting those techniques. Okay, these techniques is what we should use if the child comes in the future. That is our things. Observation is so important.
Okay, thank you.
The next speaker, Dr. Mona Lisa Saha. I think you need to go to that one.
Good morning to all. I'll be presenting my topic, knowledge, attitude and practice among parents of children with amblyopia and providing them relevant education. It is a cross-sectional study. So as we know, amblyopia is one of the major causes of visual impairment in the younger population of the world. It is defined as reduction of visual acuity in one or both eyes below 6/12, or a difference of 2 channel lines between 2 eyes with absence of any ocular abnormality that does not improve by refraction. The prevalence of amblyopia ranges from 0.8 to 3.3% in India and 1.75% worldwide. So our aim was to assess parents' knowledge and perceptions and educate them about amblyopia. So as we know, relevance is very important in today's world. Due to social media, we are aware of many diseases, but we wanted to know whether parents of today's children, do they know about the term amblyopia? So our primary objective was to estimate parents' knowledge about amblyopia and its effects on their child's development, and to fill up the gaps in their concepts. So this is a cross-sectional questionnaire-based study done in the Department of Pediatrics and Squint Services. Ethical committee clearance was taken. So at the outset, children who visited the Pediatric Ophthalmology OPD for any kind of eye problems were examined, and only those children who were diagnosed as amblyopes for the first time, their parents were enrolled for the study. Then they were given a validated questionnaire and their answers were recorded. After that, a simplistic video was shown to them and the same questionnaire was repeated again. Then a statistical analysis was done. So we expected that there will be a gap in the concepts regarding amblyopia. Total participants were 61, 27 were fathers and 34 were mothers. So this is an example of what are the questions that we asked. So knowledge questions were, do you know about the term amblyopia? So before the video, we can see a significant difference here. After showing the video, some or the other concept had gone into their minds, so they could answer at least one of the options. Next we asked, what is amblyopia? Then we asked, what are the causes of amblyopia? What are the symptoms of amblyopia? What are the risk factors of a child to develop amblyopia? What are the complications of not treating amblyopia? What are the methods of treating amblyopia? Where do you get your information about amblyopia? So as we could significantly see, the response was poor before the video, and they could answer some answers after showing the video. Attitude questions were, in your opinion, when is it necessary to take your child for an ophthalmology visit? Do you think you can prevent your child from going blind by taking the treatment early? The practice questions were, is amblyopia reversible by treatment? Have you heard of any treatment options? If yes, which treatment option have you heard of? Till what age amblyopia can be treated? And one very significant question was given, amblyopia treatment options may require you to spend some time with your child. Are you willing to spend time if treatment is suggested? So in our video, we showed them very simplistically that by 8 years of age, we can reverse it. After that, if you bring the child to the ophthalmologist, it will be difficult. So this is based on all these studies. Senthil Kumar et al. Did a study in Tamil Nadu which showed that the parents were aware of refractive errors, squint, cataract, but not amblyopia in their children. Karlika et al. In Croatia did a study and reported that no significant difference was there in the treatment success due to improvement in the knowledge. Beshek et al. reported 20% having adequate knowledge, and another study reported that some parents had some basic knowledge. So as we know, as we saw before the video, the knowledge was 10%, causes 14%, symptoms 18%, which significantly increased, and we can see here that the p-value is less than 0.001. So amblyopia is an easily treatable condition in children if the parents have some knowledge about the significance of early diagnosis, management, and compliance to the therapy. In our study, we have found that there are gaps in the existing knowledge among the parents, which we tried to fill by using a simplistic video counseling that resulted in improvement in their knowledge, attitude, and practice. Thank you.
What age did you tell we can revert amblyopia?
Ma'am, we enrolled all the children between 5 to 15 years age who got diagnosed for the first time, ma'am, and we made the parents aware that till 8 years we can still try with the help of newer modalities to help your child, and we gave them a practical knowledge about it and the true picture about what we can do.
What do you do for managing amblyopia?
Ma'am, we told them that if they bring their child and we find that there is a significant refractive error, we have to correct the refractive error. If there is significant cataract, we have to take the child for surgery. Then we also told them that it is reversible. So if there is another sibling or if anybody is there around, if any relative has, then they should.
I would like to have a to-the-point answer. What do you do for treating amblyopia?
Ma'am,
That's probably not the scope of her study. That's not the scope of her study. Let me ask something else. So your primary outcome was knowledge to the parents, isn't it? But was there any secondary outcome related to the treatment of amblyopia or the vision?
No, sir, the study is still ongoing. We have studied only 61 children.
No, that's only for the parents' education.
Parents'
The
education.
secondary outcome measures are not there, like
Secondary
visual
outcome
acuity
measures
improvement
we
and
have
things
not
like
been able
that.
to follow yet, sir.
One
Study
more
period
thing
was
you
only.
have to correct is even adult amblyopia is treatable. So you are saying 8, so that is wrong. Okay?
Thank you so much. Thank you, Vaidya. Dr. Aditya Sethi, next speaker. If he is not there, we'll move on to the next. Dr. S. Aisha Raza.
A very good morning, everyone. So I'm here to present my free paper under poster podium category, and the title of my paper is Outcomes of Toric Intraocular Lens Implantation in Children with Cataract and Pre-Existing Corneal Astigmatism. So the corneal astigmatism in cataract patient is around 0.75 to 1.5 diopter in 41% of the patients, while it is more than 1.5 in 18% of the patients. And lens aspiration and in the back intraocular lens implantation is the standard of care. Vision rehabilitation is always a challenge post pediatric cataract surgery. And uncorrected astigmatism in childhood leads to reduced visual development and meridional amblyopia. So the aim of our study is to evaluate outcome of toric intraocular lens implantation on refractive outcome in children with cataract and pre-existing corneal astigmatism. So it was a retrospective interventional study. We analyzed 16 children aged around 14 years, and the procedure performed was lens aspiration within the bag implantation of toric intraocular lens. We used JASP software for the analysis. T-test was used to compare visual acuity pre-operatively and post-operatively. Well, the p-value less than 0.05 was considered statistically significant. So 21 eyes of 16 children were analyzed. Well, the mean age at surgery was 14.3 years. Mean spherical power of toric IOL implanted was 20.82 with standard deviation of 4.04. Mean follow-up was 36 months. The 11 of the cataract were unilateral, while 5 of them were bilateral, and the steep keratometric value was 47.51 with a standard deviation of 1.44, while the flat keratometric value was 45.09. So the refractive cylinder was pre-operative, it was minus 2.91 with mean with standard deviation plus 1.22, while the range was minus 1.5 to minus 5, and the post-operative value was minus 0.5 plus minus 1.2. So the range was minus 2.2. The outlier here is because of one of the child who was a known case of glaucoma, and he underwent trabeculectomy. So the toric IOL needs to be, like IOL redialing was done after this, glaucoma surgery. That's why this minus 2.212 is the outlier here. So the corrected distance visual acuity was 0.6 logmar, and post-operative it was 0.04, and the p-value was 0.004, which is quite significant. At final follow-up, uncorrected distance visual acuity was 0.06 plus minus 0.09 logmar. So the conclusion was toric IOL implantation in children reduces post-operative astigmatism and hence improves visual outcome. However, the cooperation of child for marking is a challenge. Thank you.
What was the mean age you were having for the patient?
Ma'am, it was 14 years.
Yeah,
That
is
is
what
quite,
I've seen.
yes ma'am. The smallest children was 6 years, like in my analysis, in the children I have analyzed, the smallest one was 6 years, but that was like one only. I mean, always more than 10.
More than
Yes ma'am.
So your primary outcome was the implantation of IOL and the refractive change, or whatever,
Refractive
the correction,
change.
the
Yes,
refractive
sir.
correction,
Yes,
not
sir.
the visual outcome anyway.
Visual outcome also, sir.
So then I'm interested in the cases who had bilateral cataract and those who had unilateral cataract.
Sir, I've taken mean, sir. Mean of the bilateral.
No, what I mean is that already patients are 14 years old, they must have developed amblyopia, even with the implantation of toric IOL, they may not have improved so much. Isn't it?
Yes, sir. No, sir, but the vision was quite good in most of them. Yeah, the cataract,
Since there are no
grading.
slides, I was actually wondering, I was looking for those slides where you could have written the vision like. Anyways, thank you.
Thank you, sir. Thank you.
The next speaker, Dr. Kuldeep Kumar Srivastava. Please come.
Very good morning to all of you. I will be presenting my study on combined trabeculotomy and trabeculectomy for primary congenital glaucoma. Author has no financial interest to disclose. Primary congenital glaucoma refers to glaucoma due to maldevelopment of the trabecular meshwork, and they are
Slightly nearer the mic, sir.
unassociated with major ocular abnormalities. The incidence is 1 in 10,000 live births. They can present with clinical triad of manifestation like epiphora, photophobia, blessospasm, or you can find the various signs like megalocornea, clouding of cornea, deep anterior chamber. And if corneal diameter is more than 12 millimeter in infancy, it is highly suggestive of primary congenital glaucoma. The treatment is always surgical, various options like goniotomy, trabeculotomy, combined trap, glaucoma drainage devices, and the cyclodestruction as the last resort. Medical treatment is only after if adequate control is not there or you are waiting for the surgery. The combined trap is more suitable in Indian eyes where they present usually late with hazy cornea and have the poor follow-up. So the purpose of our study was to evaluate the result of combined trap in primary congenital glaucoma. Medical review of the records of infant undergoing a trap between January 10 to December 22 were evaluated. This is the small surgical video. Fornix base conjunctival flap with triangular. Now I am already in the cornea. Now a radial incision at blue white junction. Now the blood is oozing, means we are almost at the level of.
Sir, slightly
Can you
louder.
speak up, sir? We can barely hear you.
Now we are inserting the trabeculotomy in the Slim's canal, and if it is you are in the correct plane, it's effortless actually. Now I have broken the Slim's canal and gas of fluid has leaked. And now the same thing is getting performed on the opposite side. Now you can see the trabeculotomy. If you are in the wrong plane, you cannot rotate into anterior chamber. Now you can feel that there is a breaking in Slim's canal. And now the entry into anterior chamber is being made, and with punch we are making the trabeculectomy, and this is iodectomy is being performed. I used to put 3 sutures, and this is the final. So in post-op period, we evaluated the child always with corneal diameter, central corneal thickness, intraocular pressure, axial length, and cup disc ratio. The result was considered to be successful if the post-operative intraocular pressure was 21 millimeter Hg without medication. There was 119 eyes which underwent CCT during study period, and 65 of them were available for the analysis. The analysis showed that the success rate was at 1 year was 86.2%. Complication included 8% has the hyphema, and 6 eyes has this shallow anterior chamber, which resolved spontaneously with the conservative management. This was the child which I operated at the age of 27 days, and this is after picture after 5 months. Another child got operated at the age of 1 month, and this is after 1 month after surgery. This child got operated at the age of 4 months, and this is the 2 years post-op. This got operated at 3 months, and this is 5 years. This child got operated at the age of 2 months, then 1 year after surgery, and 5 years after surgery. So conclusion, primary trap is safe and effective surgical procedure for primary congenital glaucoma. Thank you.
Thank you, sir. This was very good presentation. I would have liked you to speak up a little. And is there anything new? Because we already know this is kind of established as a good option in cloudy corneas in children, especially in India with Dr. Mandal speaking for so many decades. Anything new that you would add in your study?
No, it's just I am doing this, so I am presenting my results.
Sir, you had not put any releasable in that. All the 3 were sutures, no releasable was put. Any reason for that?
No, in children I am not putting releasable because you have to take again under anesthesia and do the release suture. So we are not putting it actually, we are putting the fixed suture. So most of the cases it's a trabeculotomy which is working actually. So since we are disturbing the conjunctiva also, so it's a bit safer to do the trabeculectomy at the same go. Otherwise most of the cases trabeculotomy itself is a working.
And what about the bleb? What kind of bleb you are finding?
Usually flat bleb, there is no high bleb actually.
That depends on the dissection as well, isn't it?
That's all I'm asking.
Okay. The next speaker, Dr. Mansi Tripathi.
A very good afternoon to all the faculty, delegates and jury present here. So I'm going to present the results of our randomized control trial comparison of low dose versus half dose intravitreal ranibizumab in the cases of aggressive retinopathy of prematurity. I have no financial disclosure. So as we know that retinopathy of prematurity is a staggering concern in our country right now, with about 18% of the babies being born premature in our country, which amounts to more than 3 million babies, and it is India is the highest contributor of prematurity in the world. So it is important that we know of all the treatment modalities, and recently anti-VEGFs have appeared to be the upcoming treatment modalities and the standard of care in retinopathy of prematurity, especially aggressive retinopathy of prematurity. So the primary objective of our study was to assess the disease regression with the reduced dose, that is 0.1 milligram versus the standard half dose, which is 0.25 milligram of intravitreal ranibizumab in aggressive retinopathy of prematurity. And the secondary objective of our study was to study the extent of revascularization of retina after the dose and to study the recurrence of disease, if at all. So this was the method. It was a randomized controlled trial which included 30 eyes of 15 preterm babies with bilateral symmetrical AP ROP. So the reason for taking bilateral symmetrical was we introduced the standard dose in one eye and the low dose in other eye. So the confounder of the systemic stability of the child, it was ruled out, and that's how we compared both the eyes of the same baby. So the inclusion criteria were preterm babies with gestation age less than 34 weeks, less than 2,000 grams. The ROP was either zone 1 or zone 2 posterior, but with bilaterally symmetrical disease with no previous ROP treatment. And we excluded advanced disease, zone 2 anterior, patients with previous intervention done or who was systemically unfit and parents did not consent. So after screening, the patients were randomized the eye of each baby was randomized in one group, and one eye received 0.1 mg of ranibizumab and the other eye received 0.25 mg. And we serially followed up the babies at 1, 2, 4, 8 and 12 weeks. We did the anterior and posterior segment evaluation and then documented it by doing a RETCAM imaging. Fundus fluorescein angiography was done at 0 and 8 weeks only if the disease persisted or recurs under the neonatologist's care. And the growth of retinal area was mapped on Photoshop and then calculated on ImageJ. And at 12 weeks, we also did refraction under 1% atropine for these babies. So regression parameters were improvement in pupillary dilation, regression of plus disease, and the revascularization of retina. We also, progression parameters we defined as progression to stage 4A, development of sequelae and recurrence of disease, and any need for additional treatment. So this is how we calculated the area. So we took the RETCAM images. The RETCAM only takes a certain amount of area at one point. So these images were combined, superimposed, and fundus montage was created as shown here. And then two examiners mapped the vascularized area. So the avascular loop that you can see here, this is not included in the vascularized area. And after that, so we are coming to the results. We saw the regression of NVI. All the babies had regressed NVI by 4 weeks, and pre-plus disease was also regressed by 8 weeks. And the p-value was significant in both the groups, with the growth the growth being not significant. And the results, we also saw that only one child in the control group required PPV, no child required intravitreal injection, and the results were comparable in both the eyes. And complete regression was seen in 14 babies in the control group and all babies in the case group, and one child only progressed to sequelae. So the conclusion of our study was that intravitreal ranibizumab, it causes effective disease regression in AROP with significant decrease in the retinal vascular area, and the recurrence we found out was common at 6 to 8 weeks after the injection. So you need to follow up the babies accordingly. So we recommend that a reduced dose may be effectively used in treatment of AP ROP, but however, we would like to further continue the study and include more babies in our group. Thank you.
Right. So your total follow-up period was 12 weeks after
12
the
weeks.
injection.
After the injection.
And how many, anyone needed repeat injections?
No, ma'am. In our study, we did not need injections. However, we saw that there was activation of disease in 2 babies, and in both the eyes of 2 babies. So that is also related to the systemic stability of the child. And at that time, so we did a laser, rescue laser was done.
Okay, so it was laser, not repeat injection.
Yes, ma'am. Yes, it was laser because then the problem with ranibizumab is even though it increases the area of vascularization, opacization. But unlike laser, which is more effective in preventing disease recurrence, recurrence is found to be more common in IVR. However, ranibizumab has the advantage of increasing the field of vision of the child. With laser, we are constricting the field of vision, and on serial follow-up in
No,
studies.
that's okay. I don't want advantages, disadvantages.
Okay.
I just asked you what
Yes,
were
ma'am.
next needed.
Yes.
That's all.
My question, did you observe any difference in rate of progression of retinal vascularity in the eyes?
No, yes, sir. So significantly, that was what was surprising, that even though the dose was reduced to half in these babies, because like in the Rainbow ROP Rainbow study also, they have used 0.2 mg, but their recent results, they have also reduced the dose. They are also using 0.1 mg. We found that there was no difference in this thing in the vascularization rate of progression. So likely it depends on the systemic stability of the baby as well, and so we can safely use a lower dose in these babies to prevent any systemic
Were the
complications.
parents informed about this?
Yes,
that
ma'am.
one
Parents
idea
were
you-
informed, written informed consent was taken from all the patients, and we have the ethics approval of the study as well. We're still following up the babies. Now we'll come up with the 6 months results after this. Thank you.
Dr. Abhishek Shah, are you here?
Very good morning, and I'll be presenting my study on comparing the outcome of different hydrophobic IOLs in pediatric cataract surgery. Pediatric cataract is a leading cause of visual disability worldwide, and after the cataract surgery, the biocompatibility of the IOL is very important, as it may influence the clinical performance in the short and long term in the children. One of the most common IOL material used is the hydrophobic material, which allows a lower rate of anterior and posterior capsular opacification. However, a higher rate of aqueous flare and inflammatory cell accumulation on the lens surface was noted. The aim of this study was to compare the outcome among different hydrophobic material following pediatric cataract extraction based on the development of visual axis opacification, post-treatment refraction, and uveal biocompatibility. We included children aged 2 to 12 years, and we excluded any children with the history of trauma, any treatment in the study eye in the previous 3 months, or any other congenital ocular anomalies. We recruited 41 children and operated on 78 eyes. After the preliminary examination, the patients were posted for surgery and distributed into two groups randomly. The first group was implanted with an acrylate methyl acrylate copolymer hydrophobic foldable IOL, while the second group was implanted with a acrylic hydrophobic foldable IOL. The surgery was performed and the patient was followed up post-operatively from day 1 to up till 2 years of post the procedure. Out of the 41 children, 24 were male and 17 were female. In the first group, it comprised of 37 eyes, and the second group comprised of 41 eyes. Mean age among the subject was around 47 months, that is 4 years of age. So the results were in 8.11% of the group 1 children, significant visual axis opacification was seen at the age of 10.8 months post-operatively. And in group 2, 26.83% developed significant visual axis opacification. So here we can see statistically that there was higher occurrence in group 2 for the visual axis opacification. Coming to the post-op refraction, after 1 month, we saw that 94.6% in group 1 and 100% in group 2 had post-op refraction within 3 diopters of the expected, but no statistical significant difference was seen. Again, for the visual acuity, after 2 years follow-up, 20 out of 37 in group 1 and 21 out of 41 in group 2 had visual acuity better than 6/36, but again no significant difference was noted between the two groups. Coming to decentration at the 2 years follow-up, again no statistical difference was found between the two groups. The uveal biocompatibility between the two groups, we saw that in group 1 only one patient showed uveal pigment dispersion over the IOL, while in group 2 9 eyes had uveal pigment dispersion over the IOL, 3 had developed posterior synechiae, and 1 showed retracted inflammatory membrane. So here we saw statistically difference, and the uveal biocompatibility of group 1 was better than the group 2. So to conclude, there was no significant difference between the IOL decentration, best corrected visual acuity after 2 years, and post-operative refraction between the two groups. But the acrylate methyl acrylate copolymer showed fewer rates of visual axis opacification, while the Group 2, that was the acrylic hydrophobic foldable IOL, showed higher signs of visual disturbance compared to group 1. These are my references. Thank you.
Thank you. Good presentation.
Thank you.
Why did you select suprafoam? Non-affording. Okay.
Ms. Prajakta Thakur, the next presenter.
Not available?
Okay. Dr. Vivek Varkar, next presenter.
I think no. Okay. किधर लोड हुआ है?
Yes, so good morning to everyone. So basically this is the work, one of my DNB resident, she has work, and I do not have any financial disclosure. So as we all know that craniosynostosis is a premature fusion of one or more cranial suture, and it has, the estimated incidence of 1 in 2000 or 2500 live children. It can occur spontaneously and as a part of syndrome, or it could be, the hereditary, and it is always associated with n number of systemic disorders. So it can be classified as, the non-syndromic and syndromic, or you can call like non-syndromic type as an isolated, where there is involvement of single or multiple sutures, and these are the different syndromes that we do have in a syndromic variety, which is 20% in incidence. So the objective of this today's, the descriptive study is to define the demographic profile and ocular manifestations, analyze the cause of visual impairment, and what are the risk factors associated with amblyopia. So it was a retrospective study done at 4, the tertiary eye care centers, and the study population were included all children less than 18 years, and there was a sample size of almost 232 children. Those children who were less than 18 years of age, patient with both syndromic and non-syndromic category, cases that underwent neurosurgical intervention, including frontoorbital advancement or suture release, were also included, and patients who underwent ophthalmic interventions like strabismus surgery or tarsorrhaphy, they were considered. Those who are like lost to follow-up and patient with an undetermined diagnosis were excluded. So diagnosis was based on the basis of the clinical, radiological, and assessment by the craniofacial surgeons, and then the demography, history, ocular examination finding, general examination finding, and any dysmorphic features, they were noted. So age-appropriate vision testing, cycloplegic refraction, and the data that was analyzed using the Stata 13 software. So if you look at the results, I think it's more prevalent in male children. The mean age at presentation was almost 5 years. Then the chief complaints that they presented with was defective vision followed by squinting of their eyes. If you see that majority of the patients, they fell into the category of non-syndromic variety, and you see the 32% presented with defective vision, 18% referred by the treating physicians, 18% presented with deviation of eyes, and 14% had proptosis. So the delayed milestones was observed in 38% of the children. There was no significant difference between two groups in terms of consanguinity or positive family history or type and mode of the delivery when they presented in a clinic. Depending upon the sutural involvement, I think the clinically unicoronal followed by the bicoronal sutures were diagnosed more often, and radiologically the one who had the more than one suture involvement were the common type, followed by the unicoronal sutures. Visual acuity and visual impairment, if you categorize them mild, moderate, severe, and blindness as per the WHO classification, I think the prevalence of visual impairment was quite high, 64%, when we compare with the Western world. Refractive error, 54% of the patients, they had astigmatism. That was the commonest refractive error that we found. And astigmatism was found to be more in unicoronal craniosynostosis compared to, the multisutural. Then distribution of strabismus, exotropia is the most common type of strabismus in both the groups, followed by the vertical deviations. Exotropia is more common in multisutural craniosynostosis than vertical deviation. So if you look at the common causes of visual impairment, I think the amblyopia, then astigmatism, exposure keratopathy, papilledema, optic atrophy, this is what comparison with the, the different countries, that data they have published. So I think we have a delayed presentation, quite often visual impairment, optic atrophy is very common, and the amblyopia is more prevalent in our population. However, the strabismus is less common compared to the Western world. So these are the limitations, obviously, because of the retrospective nature, did not have the radiological and clinical data to review at the time of presentation, and obviously difficulty in examining these children because of systemic disease and developmental delays. So to conclude, syndromic and non-syndromic patients continue to have a high frequency of amblyopia as a risk factor and ocular problems. Incidence of craniosynostosis in our population is very low. Optic atrophy and proptosis, they are the major cause of the visual impairment. And I think exotropia is the most common strabismus type in both syndromic and non-syndromic. Thank you.
What was the cause for optic atrophy in these patients?
Optic atrophy, majority of the time they had the bilateral disc edema, papilledema, because of the raised ICT.
Nice.
Thank you. Thank you, doctor.
Thank you.
Dr. Sumita Muthu. Next present.
A very good afternoon, everyone. I'm going to be presenting about how endo-illuminator is used in pediatric cataract surgery as a guiding light, especially for beginners or novice surgeons in a dark tunnel as in pediatric cataract surgery. So these are my co-authors, and we have no financial disclosures to make. So we know that pediatric cataract surgery poses several challenges. An appropriate anterior capsular rhexis becomes a challenge, especially because of the elastic capsule and the need to use a rhexis forceps, which residents are not used to. A good posterior capsulotomy is required for this. A good visualization of the posterior capsule is essential, and adequate anterior vitrectomy is required. Again, visualizing the transparent strands becomes a challenge here. So proper visualization becomes utmost essential in completing each of these steps. So would the illumination of a microscope suffice, or would an enhancement of illumination, for example with the endolight, improve the surgical technique or outcome is what we wanted to see. So our objective was to compare the visualization of posterior capsule during posterior capsular rhexis using direct microscope illumination, and also to compare the visualization of the vitreous. So 20 children who underwent cataract surgery with anterior vitrectomy and capsulotomy by a beginner or a novice surgeon by conventional technique under the microscope light, and then later confirmed by an expert surgeon. So only non-complicated cataracts were included in this study. So first, the pediatric cataract surgery was done by conventional technique initially, that is using just the microscope light. If there was good visualization, the surgery was completed by this technique, and this was assessed at every step by an expert surgeon. Then endo-illuminator was used whenever there was a poor visualization of structures, and then the endolight was used to complete the rest of the surgery. Again, each of these steps were assessed by expert surgeon. So here is an example of how the nick in the posterior capsule is partially visible under the microscope light, but becomes very clearly visible with the endo-illuminator. So like this, at every step, if there is difficulty in visualizing the structure, the novice surgeon was not allowed to proceed without proper visualization. So we assessed for the completeness of anterior vitrectomy. This was done by the expert surgeon, and the posterior capsulotomy was again assessed for the size, centration, and for regularity. So what we found was, with the conventional technique, the beginners could complete the surgery in 15% of the cases, whereas endolight was required in almost 85% of the cases for one or the other steps. So let's look at what steps these are. So to visualize the PC nick, it was required in about 5 cases. It was required in vitrectomy to visualize the transparent vitreous strands. And in one case, it was required to complete the anterior capsulotomy because the dye was washed out. It's not moving. The slide is not moving.
Can you help her? The slides are not moving.
Yeah, okay. So endo-illuminator therefore is an inexpensive tool which helps in proper visualization of the structure and makes each of these difficult steps a little easier for a novice surgeon. So therefore it is a boon for residents and budding surgeons and acts as a guiding light in a dark tunnel. Thank you.
Thank you.
I have few questions.
Yes.
The first, there are endo-illuminators with focused light source or a diffuse light source.
Yes, sir.
Which
So
one
we
did you
use
use?
the focused light source.
The focused one.
And it is used externally. It is not inserted into the anterior chamber. It is used externally.
I know that.
on the
And who holds the endo-illuminator?
Who?
Who holds the endo-illuminator? The doctor? Or
The assistant.
The assistant.
The assistant, sometimes when you're not performing the surgical step, the surgeon himself holds, like you want to just visualize, confirm if the vitrectomy is complete or confirm the margins of the rexus, then the surgeon themselves hold it. If not, the assistant holds it. Suppose it is required to complete the anterior vitrectomy and, as the surgery is being done, then the assistant holds the endolite. Of course, it requires a little learning curve as well.
Can it not be like an attachment to the microscope? I mean, some would come with the retro, but
Yes.
if it is, then your hands are free. You know what I mean?
That is true, ma'am. But unfortunately, depending on the pupil size and everything, the distance at which the endolite has to be held varies a lot. So I don't know if we can come up with
The
anything like
best
that.
view the surgeon gets with once he or she holds
Holds
the
it.
endo-illuminator.
Yes, I agree, sir.
Or else the
Assistant,
red-free
yeah,
at
it
this
does
level.
require a
The
learning
retro
curve.
is the best otherwise.
Yes. Thank you, sir.
Thank you.
So our next presenter, Dr. Tavishi Singhal.
Good morning, everyone. I would be talking about the clinical outcomes of retropupillary iris claw IOL fixation in the pediatric population. Starting off, as we all know, insufficient capsular support in pediatric aphakics, where in the bag or sulcus IOL implantation isn't an option. We have three main positions where we can put. Either it can be anterior chamber IOLs, scleral fixated ones, or iris claw, which can both be prepupillary or retropupillary. For our study, we went ahead and performed the retropupillary fixation as from the previous studies, AC IOLs in pediatric cases, because they need to be adjusted according to the white to white, and with the ever-growing pediatric eyeball size, it has been seen that there have been a number of complications like the IOL decentration or corneal decompensation. As far as scleral fixated IOLs go, with the limited amount of retrospective studies, and in our case, as we'll see, the most common differentials for our cases, the diagnosis were ectopia lentis, in which we all know there is low scleral rigidity, so that would have affected the scleral fixated IOLs. What was the rationale behind our study? There has been a dearth of prospective studies in retropupillary iris fixated IOLs in pediatric population. So with our ambispective study, we are here to answer the question if they are safe for pediatric aphakics. Based on the literature review, as I've spoken previously, there are a number of retrospective studies which have shown good results in terms of clinical outcomes, which is BCVA, the mean refractive spherical equivalent, IOP. And so we performed an ambispective study where we took 50 eyes of 28 patients, and it varied from January 2019 to August 2021. And our objectives were, the first objective being to describe the clinical outcomes, and following parameters were used. Best corrected visual acuity, IOP, the pupil size, IOL position on UBM, any complications, which was our secondary objective. So intralenticular lens aspiration followed by anterior vitrectomy was done. The main incision was 5.4 mm, and as we are performing a retrofixation, peripheral iridotomy was not recommended as from the literature review. Results, the differential diagnosis most common was ectopia lentis, followed by microspherophakia, and a few cases of surgical aphakia, dislocated ACIL, and post-traumatic subluxation.
The best corrected visual acuity at a mean follow-up of 15 months was 0.30 logmar. The mean IOP was 13.63 at our last follow-up, and the important point here is there were no post-operative IOP spikes. Refractive error, the mean refractive spherical equivalent was slightly hypermetropic. We had performed an undercorrection of about 1.96 depending upon the age of the patient. Suture removal was done at 4 to 6 weeks post-operatively, and here we can see the spherical equivalent from post-op day 1 to our last follow-up was plus 1.12 diopters. The pupil size, as we can see, it is not hampering the dilator pupillary function because the pre-op and the post-operative pupil size did not interfere. It did not change. It was not significant statistically. It varied from 7 to 8 mm, and we could easily visualize the fundus. There was an endothelial loss of about 2.8% over our average follow-up of 16 months. The effective lens position varied from 3.35 mm to 5.20 mm. It varies because of the difference in the axial length of the patients. Coming on to the complications, we have the most common being horizontal ovalization of pupil, which became circular in every case of ours at our last follow-up. The reason for this horizontal pupil ovalization was probably because of the slight tighter tucking of the iris claw or close to the pupillary ruff. Other complications were corneal edema, which was because of the prolonged surgical time, but eventually it was all okay. 5 eyes had disenclavation, which was 2 were post-traumatic and 3 were spontaneous, but all of them were successfully re-enclaved, achieving a best-corrected visual acuity of 612 or more. So to conclude, we infer from our study that it is a safe method of IOL fixation in pediatric population where there is surgical or traumatic aphakia with insufficient capsular support, or in children with subluxated lenses, provided the iris sphincter anatomy is normal. The limitation... Sorry.
Let her finish.
Sorry, ma'am?
Finish.
Okay. The limitation being we require slightly longer follow-ups to ascertain if there is any kind of iris atrophy or pigment dispersion, which was not seen in our study with a limited follow-up of 16 months. Thank you.
What was the age of the...
Ma'am, the mean age was 8.32 years. It varied from 5 to 15 years.
Which institute have you done this?
Ma'am,
study?
AIMS, RP Center.
Okay, thank you.
Thank you.
So last speaker, Dr. Aditya Sethi.
Thank you, ma'am. My topic is, it's basically a free paper on comprehensive analysis of factors influencing surgical outcomes of traumatic pediatric cataract. So this is basically homework. The idea came from actually answering those difficult questions that parents will, panicky parent will ask you when you have a patient with traumatic pediatric cataract in your OPD. Can we answer them by just having a slit lamp examination? That's where the idea came from. And are we doing whatever we are practicing in our OT, is it actually giving us fruit? So just to do a little background retrospective study, we did this study at our center. So basically any traumatic cataract, it's any which award. And when it's a pediatric traumatic cataract, you're basically displaying it for 80 years in your drawing room. So it's something that you have to be very cautious with. So you have to strategize your battle. So in our study, we had 56 eyes of 56 children. All of them were less than 17 years of age. 2 surgeons operated on them. Both were pediatric ophthalmologists at a tertiary private eye hospital in the last 5 years, between 15 to 20. And all the results and everything we did, we analyzed retrospectively, and we actually compared it to what the literature review actually said. So this is how it presented. Most of them were actually penetrating injuries, about 66.1%, and we had most of them as boys, which both correlate with what actually literature also says. Luckily, most of them presented within 1 week to us, so the outcomes also spoke similarly. So this is a lot of literature which talks about how penetrating injuries and the location and what sort of injury generally comes along when we talk about traumatic pediatric cataract from different parts of the globe. And all of them say that wood stick injuries or penetrating injuries have been the most common type of traumatic pediatric cataract. So this is the template we have in our OT. Whenever a traumatic pediatric cataract patient comes in, this is how we approach it. If there's anti-lens capsular breach and immediate surgery needs to be done, we do a repair of the tear and only lens aspiration. We prefer not to put IOL. But if it's a delayed presentation, we do put an IOL. And if it comes as a second surgery, it means primary surgery is done somewhere else, or we've done the primary surgery and called it later, we do cataract removal and try to place it in the bag. So the prognosis, the question that is often asked is, will my child see again? So OTS is a good indicator for adults, but there's a study which also says that it can be also related with the pediatric age group, and that it talks about how soft cataracts, if it presents as a soft or a ruptured cataract, they often do much better than a total membranous rosette sort of cataract. So the visual rehabilitation of final outcome is always better. So we also found out similar findings, that if it's an open globe injury or a closed globe, really represents a different situation, where basically a closed globe would do better with, or a soft cataract would do better. And what type of visual habilitation you do also matters. If you do a PPC matters, if you do a lens aspiration matters, and the result matters. So IOL choices and treatment strategies, there was a lot of talk whether you should put IOL or not long time back, but now it's sort of established that we have to put an IOL. We often try to place an IOL in the bag. It should be a single piece IOL is what we have been taught, and we practice that, but we always keep a backup 3-piece IOL. If there's no capsular bag, then look for a capsular support and put it in the sulcus, a 3-piece. Otherwise, like our previous speaker spoke about, SF IOL, iris claw and glue IOLs in an older child is a good idea. Studies do suggest that they have done pretty well with these options as well. And we also talk about multifocals and EDOF IOLs in unilateral traumatic cataract, and that can be an option in much older children. Now, when we talk about PPC, we have to do PPC in all traumatic pediatric cataract. That's what we've learned from our study, because even however older they are, if you lose them for follow-up for even 6 months, you're not doing them a favor by not doing a PPC. So we prefer to do a PPC, and often these cases come from different peripheral zones and not really close to your proximity of your center. So it's not it's a good idea to do a PPC in all of them, because traumatic pediatric cataracts, somehow the PPC happens, the posterior capsular vasification happens much faster. And in our bag, we did most of in the bag IOL placements. So I'm going to just rush through all this. So if there's a scar, you have to get over the keratometry challenge. That is, you do your IOL power calculation preferably with over the contact lens method or the average method. Do not take the other eye. You can also have iris trauma associated with it. You have to be prepared for a secondary IOL in the longer outcome. And visual rehabilitation, basically we noticed that blunt traumas, they rehabilitated much faster. Penetrating took much longer. Soft cataracts happened much faster. The ones with iris or large scars, of course, they didn't rehabilitate all the way even after a year. And we don't really have too much numbers between single piece and 3-piece to say which one's better. So in conclusion, it's a good homework to everybody should go back and see how you're doing with your traumatic pediatric cataracts, and it's a good guidebook for you to get good results with these cases. Thank you.
Nice presentation. We usually do both eye biometry. So how does it help?
Sorry, ma'am.
We usually do both eye biometry. How does it help?
Biometry of both the eyes.
Yeah.
So generally, it gives you an indicator that how the other eye should be. But don't, what we are trying to say is don't go blindly and say, okay, the other eye biometry is there, put the lens according to that power. There's, you can either do a topography method or over contact lens method, try to come near it and then decide on it. But yeah, not very far from the other eye.
Thank you. That was it.
Thank you. We have finished in time, I believe.
Thank you to all the